Good morning and good afternoon or good evening from Cleveland, Ohio. My name is Ashok Agarwal from Cleveland, Ohio, and today is Saturday and March 28th. I'm very happy to announce the beginning of today's program, which is the third in our session of online academic session offered by the Global Andrology Foundation. This is an initiative that our organization had taken to bring a lot of interesting and controversial topics to our membership as well as those outside of the GAF in a more creative manner. For example, today's program is a debate, and we have done different formats of topics in our previous meetings over the months. So every academic session is done every 2 months. So we had one in January, and now we have it end of March. Today's program is titled Regenerative Therapy in Erectile Dysfunction, Boon or Bane. So whether it is some kind of a benefit or it is a curse. And the program has the leader or our moderator is Professor Pinggera from Austria. And our main speakers, which will be introduced more formally by Dr. Germar, are those in favor of this treatment, regenerative treatment, is Professor and Dr. Manaf Al-Hashimi from United Arab Emirate. And the one on the opposite side who will discuss the problems with this kind of treatment therapy is Dr. Mohamed Arafa. Professor Arafa is from Qatar, from Hamad. And then at the end, there will be expert comments, which will be delivered by a panel of our experts, which include Dr. Marco Falconi from Italy, Vidi Atmoko from Indonesia, and Tunce Toprak from Turkey. Dr. Germer will deliver the closing remarks as well and conclude the session. At the very end, after the program ends, we will provide a QR code, which when you project your camera, will give you the link or guide you to the link where you will have some questions that leads you to a survey. And as you complete the survey, when you enter your name, it will deliver a beautiful certificate of this program in your name. So all of it is automated, and it kicks in once you go to the link and fill out the information and complete the survey related to the questions. So without any further delay, I am now inviting my colleague, Professor Germer, to begin the program. Dr. Germer?
Yeah, good morning, good afternoon, and again, good evening to someone who are joining us today. So wherever you are in the world, we see so many persons around in this chat here. A warm welcome to this online meeting today organized again by the GAF. So today we gathered to explore a topic that is both timely and clinically relevant. This regenerative therapies for erectile dysfunction, Boon or Blame, is that we are interesting to understand. So we have an outstanding panel of international experts, as mentioned before. So with us this morning, and I'm looking forward that promises to be stimulating and through provoking debate. Let us now go started. I'm not sure that now it's working. So I see, sorry, one picture is not working. So allow me briefly to introduce myself. So I'm Germar Pinggera. As Professor Eschak mentioned, I'm working here in the Medical University of Innsbruck. Indeed, I'm right at the hospital in Austria. And I have a long-standing interest in sexual medicine and but obviously right now in regenerative approaches too, which makes for me moderating today debate both a privilege and more personal passion. So I'm very much looking forward to guiding our discussion today. And we will see that this will be a huge discussion, a huge battle, we'd say, in a boxing ring, ensuring that we can make the most of the excellent expertise our faculty brings on the table here. Here is the program for today to remember what was shared recently by email. So we have here the one side, the most important thing is the guest speakers, Dr. Al-Hashimi, which will argue in favor why, and he will explain why regenerative therapy in ED is a boom, whereas followed immediately, Dr. Arafa from Qatar will making the case that is a Bane. So following this one, I will invite subsequently our three experts over the world, Marco Falcone from Italy, Vidi from Indonesia, and Professor Tunçay Toprak from Turkey. And together they will see what's the end, and that's a really fascinating program. You see that's really interactive what you're planning here. Here you can see the persons which I would like to warmly welcome all these members for our distinguished faculty. So join us today from UA, Dr. Manaf Al-Hashimi. You will see the picture here. He is the first fighter, the strong fighter from UA. And then Professor Mohamed Arafa from Qatar will explain how he will battle the situation. So our experts, commentators today are below. In the picture you can see Dr. Marco Falcone, Professor Falcone from Italy, Milano, and Professor Tunçay Toprak. He is from Turkey. And you see, we have done everything in the world. We invited Professor Vidi Atmoko from Indonesia with a different time zone, but we are delighted to see that. So with this truly global gathering, so colleagues from across 4 continents, it's a privilege for me to have you all here. And you know your audience will be a benefit enormously from the insights, and with this one we can proceed. Professor Ashok Agarwal, it's my pleasure. He is always our mind behind the GAF. He is organizing everything with a high enthusiasm. No time where he is not available. 24 hours per week he's working, so that's great. And in the background, Professor Rupin Shah, again, he helped us a lot. And unfortunately, as I heard today, he cannot join, but he has done in the background all the program work for the scientific program. So with that, so let me leave you with the spirit that drives this meeting. I would say science made better. So that's our shared goal today. Not just a debate, but to advance our understanding and ultimately improve the outcomes for our patients. Let me move to a brief introduction to the topic itself. So regenerative therapies and erectile dysfunction, the science, the promise, and the question that still remain. Then we had the floor for our first debater. So here for regenerative medicine, I think we have really to make a clear cut. So we should understand what do we need to know. So I'm right now happy for this meeting because I think it's one of the most important, which actually is triggering all the congresses, all the patients are coming, asking what we can do and what we can share. So the central challenge in this field, I think, can be summarized and summed up in 4 words: separating signal from noise. That's the state of science breathing here. And my goal over the next minutes is to give you a honest, evidence-based introduction of where regenerative therapies for erectile dysfunction actually stands today before our 2 guest speakers will jump in the arena to battle and to fight about. Basically, let me start. It's a question of the biology. The promise from regenerative medicine is fundamental completely different from that we have the last 20 years with PD-5 inhibitors. PD-5 inhibitors work symptomatically, as you know. They cause a temporary vasodilation with the nitric oxide pathway in the penis. Now, with regenerative approaches, the aim is to repair or to rebuild the penis. So there is the question, can these techniques trigger somehow the neoangiogenesis? Can they do some kind of endothelial repair or nerve regenerations through growth factors, cytokines, VEGF, PGF, TGF-1? So we are not just dilating vessels, as like we're doing with PD-5 inhibitors. Now we are attempting to regenerate the tissue itself. And that's a promise. And we would like today to understand if that's true or not. So why now this is matter for us? So the number are sobering. As you can see, then in the last projection by the WHO, we have around 322 millions of men worldwide which are affected by AD, and the prevalence reaches 52% in men in the age between 40 and 70 years. Critically, 35% of patients are either non-responders to PD-5 inhibitors or have some kinds of contraindications, which are not allowing to make the prescription for these PD-5 inhibitors. And overmore, 30 to 40% of prostatectomy patients neither do respond to the standard therapy. So these are the patients where regenerative medicine must address. So looking at the current evidence hierarchy, you can see in the upper part of the image here, shockwave therapy. It might be the most studied modality with larger studies, many studies. We will see 21 RCTs only reviewed by the Cochrane analysis in 2025. But you can see even less PRP data covers nearly 1,000 patients. Then is stem cell therapy, remains in an early stage, but if you look in detail to the evidence grade, there's a range from low to very low certainty across all these modalities. And we have to understand. So at first, for our understanding in this non-surgical treatment, I will cover the low-intensity shockwave therapy. So this mechanism is an acoustic wave-driven angiogenesis. Is completely different from what we have been used in urology for the kidney stones, defragmentations, whereas it's working more by stimulating new blood vessels formations, some kind of tissue regenerations through the sound waves. So it's delivered in different protocols, maybe in 6 weekly sessions for 20 minutes each. It's painless. We tried it, requires no anesthesia, and shows some cumulative improvement over 2, but even less over 3-4 months. So importantly now, it's on the line that the EAU guidelines endorse that for the ED treatment, at least for some subgroups, and the only regenerative modality that have reached that threshold. But we have other ones. Indeed now, this brings us to the second of the 4 major and important techniques in regenerative therapy for ED therapy. That's here the platelet-rich plasma. PRP uses now the blood from the patient's own blood to support the healing, improve the blood flow in the penis, and enhance nerve signaling and promote tissue repair. PRP has a long history in medicine, in orthopedics or in plastic surgery, in anesthesia. So that's a well-known therapy. And now it's under a non-surgical outpatient procedure that usually takes about 30-45 minutes with a couple of sessions separated between a couple of weeks, 4 to 6 weeks apart. And because they use the body's own biological material, downtime is minimal. Evidence also suggests that PRP may improve erectile function, especially in patients with vasculogenic erectile dysfunction. At third, we will get some information about botulinum toxin, used here as a kind of neuromodulator and not as a cosmetic agent. completely different. That's in plastic surgery or in neurology. So the mechanism here, Ryan, is the relaxation of smooth muscles in the corpora of the penis, along with some kind of relaxation of the arterial vessels. This leads to an enhanced nitric oxide release and improves the coverage of blood penis. So it's an in-office injection therapy, highly attractive, keeps only 15-20 minutes to do it. And the effect begins in after 1 week, 2 weeks, and is subtly increasing. So as we know it from the urinary bladder, where we're using it for a longer time, and it's I had a lasting therapy for a couple of months, 4-6 months. And early evidence is partly promising for a special group for the neurogenic and diabetic ED patients. So patients, populations where very limited therapeutic options are, because they normally are not good responders for PD-5 inhibitors. And fourth, it's maybe the most cutting edge, that are the so-called exosomes therapy. These are stem cells-derived microvessel, so biological nanoscale packages that carry regenerative signals into damaged cavernosa tissue, maybe activate some repair mechanisms, reduce inflammation, and aiming to restore erectile dysfunction in implanting living cells. So it requires one injection normally, and uses off-the-shelf allogenic formulation. It has maybe a good, excellent safety profile compared to the classical stem cells therapy or the genetic therapy, what we learned 10 years ago. So the first clinical data from 22-24 shows some rapid improvement, but we are still very early in the evidence curve. So maybe that I will pick up one therapy. So let me zoom in the PRP procedure, because it's highly important to understand. And there we will understand why we are invited two experts, which are detracting the statistics, the data in detail. They investigated a lot of time to understand, which is good. So I want to highlight some aspects here. For sure, will be more elaborated now by our two guest speakers. For the PRP, we are retrieving some blood from the cubital vein, 15-30 milliliters, and we again go into centrifuge. As you can see on the image, that is highly different what we are using. We are using different amounts, and we are putting that back. We have a different centrifugation rate between 3,000, 5,000 rounds per minute. The time is different, but at the end we have an increase of concentration of platelet, which we can inject hereafter. And the standard protocols are really confusing. So only to make a short introduction, you can see importantly are these first RCT studies by Paulius 21. You see he gained, he showed a meaningful IF increase by nearly 4 points, even less after 6 months, which is nearly 70% for the PRP, better than for the achieving a clinical relevant erection compared to the placebo group. But then you can see the study from Masterson 23 showed no statistical significance between PRP and placebo at 1 month. The TAS study in 21 showed a modest improvement, but it's an uncontrolled metabolic ED patients. And indeed, here the IF remained in the mild moderate dysfunction rate, so not a huge benefit for our patients. You see, the picture is really heterogeneous, highly difficult. And if you're looking now to meta-analysis, the situation will neither be easier to understand. So we have a few meta-analyses meanwhile about this specific topic, which are going to synthesize the data. From China, we have the study from Huatang Huang. In 24, he included 10 studies, nearly 600 patients, 559 patients, and he reported a sustained IF improvement, plus 4 points at 1 month, and nearly 4 points again after 3 months, which is significantly high achievement versus placebo. However, in my opinion, it's really critical, and the critical pricer box at the bottom tells you the real story. Heterogeneous PRP preparations, majority of study with high-risk bias, protocol standardization not clear, remain the single greatest barrier here for the clinic adoption. And we have to learn this is the core tension. And I want you to take home with you. Two peer meta-analyses published in the same area reached diametrically opposite conclusions. As mentioned before, the Hewing studies from 24 included showed that a significant efficacy and safety for PRP. And then the Amarin study 26, published a couple of weeks ago, concluded PRP therapy do not confer superior efficacy over placebo. So same intervention, same literature, and opposite verdicts. Why? That's what the next slide will explain to you. You see, if you look, the explanation lies here in the methodology. We have to be careful, and it's not a question of biology. The Hewing included 10 studies, 3 RCTs, plus 7 single-arm trials. And then he reached a high number of 559 patients, whereas the Amarin study included strictly 7 RCTs, a lower number with 479 patients with no single-arm data. And the key differentiator highlighted in gold in this slide is precisely the inclusion of a single-arm study is that tweak the Hewing data. When there is no control group, IEF scores improve simply because patients expect improvement. So strip those single-arm studies out and the advantage of PRP over placebo becomes statistically non-significantly. Here you can see exactly what I'm meaning here. What is the factor for PRP compared to saline? And with a SMD from 0.26, I calculated this again, to 0.4, that's not statistically significant. So we have here a lot of different studies. We have a lot of different meta-analyses. As you can see, some are reporting no superior efficacy, some reporting some efficacies. We have to understand, and that's the key point right now for this highly interesting talk, what we are going right now to introduce. And we can see what is reality, the clinical reality, what's a regulatory reality, what we have to learn. And with that one, I wanted to now to ask Dr. Professor Al-Hashimi to share his slides. And I strongly encourage you to battle in favor of all these different techniques. I showed only the difficulty for one technique, but I know you're the expert, Mr. Manaf, for showing us what is the benefit from all the other ones. So welcome to you, Professor Manaf Al-Hashimi. My great pleasure to see you here. And can you share your pictures right now, your image right now?
Thank you very much, everyone, for the attendance. As my presentation is displayed, right?
Yes, Dr. Manaf.
Okay, thank you very much. Greetings for everyone from the elegant city, Abu Dhabi, United Arab Emirates, where I'm practicing since last 20 years. And honestly speaking, I agreed with Dr. Germar that the erectile dysfunction presentations, and this is what we notice in all our clinics, that the patients' populations of erectile dysfunction is increasing. And honestly, it's not like before. Even we started to have young and middle age who complaining of erectile dysfunction. This population-based survey in the United States, and it showed that if we look here on this column, the age from like 18 to 34, and the second column, 35 to 49 years old, and they are really complaining of erectile dysfunction severity, maybe severe ED, even 6.3, while for total is about 40% of them have different grades of erectile dysfunctions. And maybe before we are saying that it is psychological, not organic, but honestly speaking, we have many comorbidities in young and middle age, especially the, let's say, smoking and the obesity as very well displayed in this different studies, whether from Europe or other areas. And this study nicely showed the correlations between the obesity, smoking, and the severity of ED. So if we are expecting 35 years old and he's smoking since 15 years, since the age of 20, definitely he will have vascular erectile dysfunctions. Another very important morbidity factor is the diabetes. Everybody knows that sedentary life and loss of exercise and lifestyle are not really healthy in many of people, make the obesity is very high in all over the world. And we can see from this chart that patients with diabetes, even young and middle age, have diabetes more than 10 years. Maybe they presented at the age of 35, 40 with severe erectile dysfunction maybe, and really it's organic. And in this study and in this particular group of patients, the young and middle age, what is the standards of treatment of erectile dysfunction? We have almost important first-line standards, which are BD5 inhibitors. But honestly speaking, very resistance from these patients to accept this as a modality of treatment. And this is well documented in this study also, when there are labeling the BD5 inhibitors, majority either unsafe or uncertain about starting this modality. Why? Because they feel there will be risk of dependence, serious side effect, potential cardiovascular risk, or uncertain. They are reluctant in our clinic to start, especially in many cultures where the BD5 inhibitors consider the stigma. Doctors, why I have to start BD5 inhibitors? I'm only 35 years or 40. So these populations, the young and middle age group, in addition to the non-responders to BD5 inhibitors, I know there are 30% are not responding, even if we are fixing the BD5 inhibitors modality of application. We can increase the dose, we can shift to another BD5 inhibitor, we can combine short acting with long acting, or optimize the hormone, but still 30% of them non-responders. So what we have to offer them? Intraurethral alprostadil, intracavernous injections like Coverject, vacuum, or penile implants. All of these modalities are invasive and they don't feel very much easy to start them because they fear from, you need the preparations for the injections, for the cream, and penile implants also is very much invasive for them, especially the young and the middle age. So I think when we got the introductions of regenerative therapy, like shockwave therapy and PRP and the stem cells, here were the most of the young and middle age or non-responders looking for these modalities, and they like to try it. And whatever we have evidence, sometimes or incomplete evidence, many patients presented to the clinic asking for these modalities. And especially the thesis behind these modalities are the repair and of the cavernous tissue. Repair of the tissue, not like on-demand BD5 inhibitors in form of angiogenesis, endothelial restorations, neuronal regenerations, smooth muscle regeneration, antifibrotic effects, anti-apoptotic effects. This is not only flags, because many preclinical data showed there is significant improvement in these basic factors, whether the nitric oxide or regenerations of the cells or the angiogenesis or many other objectives. Of course, I would like to show you some only of the meta-analysis. This is for shockwave therapy, which is the first one to start, maybe 2014 and after, and the most extensively studies. Many of the systemic reviews started the volume of patients from 800, 600, 1,000 and other more than 1,000, and looking for the important endpoint and outcome of any modality of treatment for erectile dysfunction, which is the erection function score, the IIEF. And even some of them, they're looking for the erection hardness score and maybe other objective evidence like peak systolic velocities and others. And nicely, we can see in many of these studies, the patients responding very nicely. And this is another study showed, and this is it is of the GAF. This is the study of the GAF about the systemic review and meta-analysis about shockwave therapy. Although mentioned there is no significant effect on the peak systolic velocity and end diastolic and so on, but the IIEF, there is significant improvements. And this is where the patient looking for, because sometimes we are looking only for the basics to prove the modality, but maybe the basic like peak systolic velocity and the others we are looking at the research not always consistent. And this is maybe was very well managed in this study, where showed that invented a new one is called visual erection hardness score, and they found it is very correlated with the peak systolic velocity measurements. And in this study showed that the shockwave therapy effective in the treatment, especially in mild to moderate vasculogenic effects. And this is another landmark umbrella review for the shockwave therapy, when mentioned that 4 or 5 studies showed improvement in erectile function. And they are raising a very important protocol, because one of the criticizing point, we don't have consistent protocol for this regenerative therapy. But at least for this shockwave therapy, they mentioned that the best protocol using energy density of 0.09 microjoule and the application of 2000 pulses per shock per sessions, and maybe 6 sessions. And they follow the patients for 6 to 12 months, result in greater improvements in ED, even compared with the 3 months. If we look for the recommendations for shockwave therapy, this is the ASIA's Pacific Society for Sexual Medicine position statement, when showed that the low shockwave improved the erectile function score and penile hemodynamic parameters. So there is subjective and objective improvement in vasculogenic erectile dysfunctions. And it is effective and should be mostly restricted to men with mild to moderate vasculogenic erectile dysfunction, whether responders or non-responders. And also there is a statement it is safe and well-tolerated procedure. And if we look for the European guidelines, also mention that the shockwave therapy have evidence, especially for mild vasculogenic erectile dysfunction, alternative therapy for patients who don't wish to start the BD5 inhibitors. And this is very characteristic of our populations, middle age or young patients who are not willing to start BD5 inhibitors, or even with non-responders to BD5 inhibitors. What about the stem cells? Stem cells, we have, of course, as you know, some of the stem cells taken from umbilical cord is called allogenic, and some of them we can take it from adipose tissue of the same patients, which is the autologous. And we are using, at least in our area, the umbilical cord tissue and very licensed banks, and can give you injections of 4 ml to 6 ml, contain about 50 million stem cells. This is not something considered with that logics, because there are preclinical data, and also there are many studies showed there is improvement, whether in the erectile function score or peak systolic velocity, and the modalities of enhancement, the mechanisms is mostly paracrine. And as Dr. Germar mentioned, not only the stem cells, but the production of the stem cells, which is exosome. So whenever you insert the stem cells in the cavernous tissue, will produce exosome itself, or you can give directly exosome injections, although maybe will be less effective than the stem cells itself. And this is one of the very important studies showed there is significant improvement in peak systolic velocity in the stem cells comparison between 1 and 3rd month and 1 and 6 months on the left side. And here we can see the improvement in the erectile function score for the stem cells. And another important systemic review that show there is significant improvement after injections of the stem cells regarding the erectile function score, and nicely the duration, some of them up to 1 year, and showed significant improvement. Is that end of the story? Actually, no. We just started. We don't forget that this is new modalities. We have a newly emerging studies every time, and look for this study about the stem cell. It is a bibliometric and visualization analysis. We can see the studies how much they are getting more and more every year, and we can see they are the top 10 countries producing the studies about the stem cells. So if we are waiting for evidence, we can wait, and definitely we cannot say no for these new modalities, because definitely with time we'll get maybe more supportive evidence. About P-short, about PRP, nicely was showing also by Dr. Germar. This is one of the important meta-analysis, and we can see even for the quality assessment here, it's showing that the majority have low risk of bias. While look for the assessment of these all studies, it is all in favor of PRP in enhancement of the erectile function. And also here, it is the randomized control studies with 2 years follow-up, and they looking for the erectile function score, for the visual analog scale, for the cavernous artery diameters, for peak systolic velocity, subjective and objective, and all of them in favor of the PRP. This is a new study of GAF, and showed there are 3 studies are actually randomized studies, and they are in favor of the PRP. So from all of these, what about the patient looking forward? Of course, the patient showed major interest in these new modalities. Look for this study, batting Google research interest of patients in PRP and shockwave therapy. It's increasing from 3-fold for P-shot and by 275-fold over 1 decade. See how much the patients are very much interested in these new modalities.
Oh ya, itu gelangnya bagus tuh. Bawa ntar gelangnya.
What about the urologists doing in actual practice? This is our GAF global survey, the first ever global survey about regenerative therapy. We got 479. It was done in 2024. We get more than 479 responses. 1/3 of them, they are using or utilizing regenerative therapy, mostly shockwave, P-shot, PRP, and or combination, and then the least is the stem cells because they are expensive. And when we ask them, the 2/3, why you are not using the regenerative therapy, the most common response: no experience, not covered by insurance, none availability. So I think the interest, even with the urologist or andrologist or utilizers, are there, but there are some restrictions. It's not related to the efficacy or to the guidelines at all, but it is related to the cost and the availability in their centers. And when we ask them about the improvement after regenerative therapy, here we can see if there are very few from their patients improving, they said only 16%, but all other responders, they said we have good response either in 25% of cases or up to 50 and sometimes more than 50. So we have in practice enlisted responses of patients. Now, if I ask them how long the improvement continue, we can see for different modalities, maybe the majority from 3 months, followed by 3 to 6 months, and maybe 6 to 9 months. And when we asked them comparison with the BD5 inhibitors, the best responses was, or best scoring was for stem cells and shockwave therapy. I think there is evidence, there is response, but the problems in protocols. We cannot blame the modality maybe, but because there is no till now an actual protocols of treatment. We can see how the heterogeneity, everybody using the modalities differently, whether shockwave or P-shot or the stem cells. That's why the studies outcome sometimes becomes heterogeneous and we don't get enough recommendations. So the problems that we need actual studies. We cannot cross over these modalities treatment, but the problems mostly in our utilizations, in our guidance, we don't have guidance enough to look for the best patients and best protocols. But we guaranteed the safety, and we look for, when we ask who responding, the most of them, they said very safe, and even if there is side effect, is only minimal, like bruising. So we can guarantee at least the safety. And the responses from our survey also in favor, they say the best responders are the mild to moderate erectile dysfunction and the patients who are young or middle or middle age. So we have at least concepts from the urologist or andrologist who's using, along with the conclusions of many studies, that are the best responders are middle age and mild to moderate erectile dysfunctions. So I'm with these conclusions, I'm totally agree with this study. The problems, we don't have a standardized technique for isolations and activations, whether for PRP or growth factors. And some of them that are using, as Germar showed, 30 cc for P-shot. We have machine, we are using 80 cc because whenever they increase the volume of blood will get more growth factors for PRP. For stem cells, some of them, they say 50 million. We have another bank here in United Arab Emirates. They say, no, it's, I think 20 million of stem cells will be enough. So we need to standardize. Whenever we get standardizations will be the best. Various method of activations, no clear protocol of administrations, no long-term follow-up, and no criteria for patient selection, and no predictive factors. This is what the studies are. But we need to improve all of these parameters. Definitely the studies outcome maybe will come with different and will be in favor of the regenerative therapy. Myself, I'm using these modalities with the conditions. I know this is not a standard treatment, but it is effective in some patients. But we need to have careful patient selections. Again, middle age and mild to moderate erectile dysfunction. We need not to criticize these modalities. We need to give them, but in the same time ask the patient to do exercise, to take healthy food, to control his testosterone, to control his obesity and smoking and all other comorbidities. And this way we can get the best outcome. And we can combine also the best outcome, not only with shockwave alone, but with shockwave and P-shot, or sometimes if are not responders with the BD5 inhibitors. We need to give adequate treatment cycle. We cannot challenge P-shot with one administration only and say there is no response. Sometimes we can give after 3 months or after 2 months, or we give shockwave repeating, we get better response. And also, we need to look for the high quality biological preparation, P-shot and PRP. When we examine the outcome of how much platelets containing, sometimes the same like plasma, they are not considered enough quality machines to give you high platelets rich or platelets rich preparations. And we need to have adequate follow-up and outcome, and we need to participate in real better quality clinical trials in order to give the best score and the judgment about the regenerative therapy in ED. Thank you very much.
So thank you very much, Dr. Manaf. You have my compliments, at least for this wonderful talk, where you try to convince now all the audience. We will see how is the voting here after the end, and if you could really convince each one that they should use your practical daily therapy plan, even as mixing several things and considering all the different pathologies. So therefore, when you convinced all the audience here, I will see how our good friend, Professor Arafa from Qatar, is coming now in the ring. And Professor Mohamed Arafa, welcome. Now it's your turn. I wanted to hear exactly what you're stating. Should we do all that, what Professor Manaf is arguing? Are his data so valid that we should use it? Please, I'm delighted to follow your lessons right now. Thank you very much.
Thank you very much, Germar, for the nice presentation. Can you hear me well? And can you see my presentation?
All fine.
Okay. So I'm Mohamed Arafa. I am a professor of andrology in Cairo University and currently working in Hamad Medical Corporation in Qatar. Today I'll be presenting the Bane side of the regenerative therapy in erectile dysfunction. First of all, I have no conflict of interest to declare, but I have one declaration. Dr. Manaf is my dear friend, and I'm happy that I am on this side of the table of this debate.
Sorry, I interrupt you. You are doing your job right now, not family, no friendship. Come on.
So thank you for Germar and Dr. Manaf, because they made a very good presentation about the mechanism of action and the burden of erectile dysfunction. So I will go directly to my point. I'll give you some evidence, and then at the end, you will reach the conclusion by yourself. First, let's have a question: how to establish evidence benchmark? And here I will take one very good example, which is the PDE5 inhibitors, our gold standard model for management of sexual dysfunction. So it's in the same field. How did it become the gold standard? First, it has clear biological mechanism. It works on the nitric oxide cyclic GMP pathway that is responsible for the hemodynamics and vascular function of erection. So it is well-established mechanism of action. There are very high quality clinical evidence with multiple large RCTs, significant improvement in the international index of erectile function, and around 6 to 7% improvement in the SEP3 question for PDE5. Then it is reproducible on all patient population: general ED, diabetics, hypertensive, post-prostatectomy, cardiovascular patient. Everyone there is proven efficacy. Standardized dose, standardized onset of duration, comparable between all the studies, and there is no heterogeneity or minimal heterogeneity, but with constant effect. Then the long-term safety data that is present there. We know its efficacy, we know exactly the adverse effects of each of the medications, and we know the clear contraindications for them. This all together will give us the gold standard. And how did it reach there? First, it started in 1998 with introduction of Viagra, and it was accompanied by a huge multi-center randomized controlled pre-marketing study showing its efficacy. This was again confirmed by individual studies all over the world that showed the same results. These were pooled in a meta-analysis, multiple meta-analysis, and the pooled data showed moderate to large size effect consistently around the trials. Accordingly, it went through the guidelines, all of them approved it as a first line, and it became a part of our clinical management for erectile dysfunction. So this is the way to go if you want to put a treatment for erectile dysfunction. Coming to our second evidence here, I'll tell you some facts. The first fact, when you come to the level of evidence in science, this is The highest evidence is coming from meta-analysis and meta-analysis of RCTs, because meta-analysis, if you give it rubbish, it will give you a pooled rubbish at the end. But if you give RCTs, which is the highest form of clinical trials, it will give you the best data. Then systematic reviews, RCTs, cohort studies, and the least are case series or expert opinion. This is not my word. This is according to the Oxford levels of evidence. The second fact, there is something called placebo effect. What is placebo effect? That the patient benefits from the placebo and not from an active treatment. How does it work? It works because the patient is expecting that he is taking treatment. So according to his expectations, he's showing some improvement. There is some psychological process here. We are fooling the patient of his having psychological ED, so psychologically he is responding. And there is actual neurobiological changes, same like the Pavlov experiment. The patient is giving a treatment, there is some sort of release of neurotransmitter that will make some improvement, not the maximum improvement, but some improvement. This is not only in the sexual medicine, it's all over the science, all over the treatments, there is a placebo effect. And in some of the studies, it reached up to 60% of the treatment outcomes. Does this occur with erectile dysfunction drugs? Yes, this is a very nice systematic review and meta-analysis of 63 randomized placebo-controlled trials, including more than 12,000 patients. And it showed that although the placebo was less significant effect than the active PDE5, but it showed significant improvement in all the erectile function domains. Erectile function, intercourse satisfaction, overall satisfaction, sexual desire, everything. So there is a placebo effect. Coming to our last fact, we have to confirm that regenerative therapy is there. It is a fact, and we have to live with it, but we have to see how we can deal with it in a best way. And as Dr. Manaf said, this is the survey done on 479 participants across 62 countries from all continents of the world. It showed that more than 50% of them are using shockwave, quarter are using PRP, and less than 5% are using stem cell for erectile treatment of erectile function. So it is there, and we have to deal with it. Now coming to the third body of evidence, which is the clinical evidence, and this is the most important. Let's take it one by one. Regarding the low-intensity shockwave therapy, you will find this extensive advertisement all over the internet, all over Instagram, Facebook. It is always there. Shockwave therapy, regenerate your health, your erectile function, become youth again. So let's see, is the evidence really suggests this? This is the systematic review and meta-analysis of randomized controlled studies. So this is the highest evidence ever that we can talk about, done by our Global Andrology Forum group. They identified 12 studies, 12 RCTs. So this is very nice. There are 12 RCTs on shockwave therapy. But let's go deeper here. Let's dig deeper. You will find a quite heterogeneity in the protocol. We'll use it from 3 weeks to 9 weeks. Number of sessions per week, number of pulses given, number of joules given. So it is all over the place. And then the follow-up ranged from 4 to 24 months. So again, we don't know the effect, how long will it stand the effect. And when we come to the outcome measures, we'll find that most of them are dealing with the International Index of Erectile Function and the Erection Hardness Score. These are good scores to deal with, but they don't reflect the real hemodynamics. These are surveys, and whenever there is a survey or a questionnaire, it is liable to bias because it's not objective, it is subjective. So you will find only 2 studies that tested the improvement in the real hemodynamics by Doppler. What did they find? Dr. Manaf showed this. They found significant improvement in the International Index of Erectile Function, the short form and the elongated form, but with moderate to high heterogeneity in the studies. All other domains, erectile hardness score, SEP 2 and 3, global assessment questionnaire, the Doppler, all of them were not significant. So they concluded that it proves modest improvement in erectile function score, but none other scores. While it may offer some benefit, the clinical relevance is limited for most of the patients. Clinical evidence doesn't support its routine inclusion in erectile dysfunction treatment algorithm, and future large studies is needed to provide it the validity of its use. Let's come to another very important part that Dr. Manaf have lightly went through it, and it's not his fault because the literature even is not discussing it very well, which is the safety concerns. They always say shockwave therapy is very safe, but there are some theoretical risks associated that we have to think of, like the hematoma can cause fibrosis, it can cause nerve irritation and pain, it can be chronic pain. Even the angiogenesis that is produced, it can be dysregulated angiogenesis. It may lead to accentuation of venous leakage and may lead to potential erectile dysfunction exacerbation. So we believe that the adverse effects are really underreported or underdocumented in these patients, or due to the short-term follow-up of these patients, the side effects didn't appear yet to be there. This is contradicting with FDA approval requirements that said that FDA-approved treatment should demonstrate superior safety profiles with extensive clinical validation. And again, the post-marketing studies are still very deficient because it's only very few years since it's there. So to wrap it up for the shockwave therapy, the treatment protocol standardization is not there. The trial design is very heterogeneous, so the meta-analysis is not conclusive. The publication biased towards the positive outcome and with little light shed on the negative outcomes. The mechanism itself, we say that it produces angiogenesis. How much angiogenesis? Where angiogenesis? Is it all through the penis or only through patchy angiogenesis? Is this enough for producing regeneration of the penis or not? This is not still very evident. And of course, the long-term follow-up data is still lacking. And this is why when you look at international guidelines, the AOA said that it's investigational. The Canadian Urology Association and the SMSNA said that the evidence there does not support its efficacy as a treatment for erectile dysfunction. The European Association of Urology was a bit lenient, said it should not be the first line of therapy, may be offered in mild, and we come to mild vasculogenic erectile dysfunction. These are the patients who, when you leave them alone, most probably they will respond. They don't need a treatment or need very mild supportive treatment. Patients who are unsuitable for or unwilling to use PDE5 or poor responders. And again, all these patients must be consented about the low efficacy or the low evidence of efficacy. And the Italian Association, again, said the same. Weak recommendation in improvement is modest. Hemodynamics and long-term safety is still uncertain. Now, coming to the P-shot, the PRP, or I call it the headache in my clinic, because patients are usually coming asking for it due to the extensive advertisement about the P-shot, the magic shot. When we see the evidence quality for PRP here, we'll find that it's mostly coming 40% from case reports, 50% from observational studies, and less than 10% from RCTs, with a decreased sample size and short follow-up duration and modest improvement of international function over the controls. This is the very recent meta-analysis and systematic review of the randomized controlled trials. Again, this is the highest evidence. They identified 7 studies. This is very recent, in January 2026, published in January 2026. So again, we have 7 studies. This is very nice, but again, when we dig into it, you will find patient sample size very small. The maximum is 60. Coming to the centrifugation method, and here you will find it all over the place. Different centrifugation power, different timing, and then again, as Dr. Manaf has said, coming to the volume injected, it's different from one study to another. How many sessions? Different from one study to another. And the most amazing part is only 2 cases stated of adverse effects, 1 hematoma and 1 plaque through all these 7 studies. And the meta-analysis, the pooled data, found that there was no significant improvement in all domains, International Index of Erectile Function, the orgasmic desire or satisfaction with PRP over placebo. So they concluded that the current evidence doesn't support a consistent clinically meaningful improvement in erectile function with PRP monotherapy compared to placebo, despite its being very good rationale and safety profile, but still the heterogeneity and small sample and methodological limitation is hindering its efficacy, and they recommended for larger studies. When we come to the safety concerns, the 2 patients with side effects that reported, but when you think about it, there is more theoretical risks than this. There is infection that can cause hematoma, that can cause fibrosis, that can potentiate more erectile dysfunction. And definitely there is underreporting of the side effects. And again, this contradicts with the FDA, and there is no post-marketing surveillance up till now. But we have to dig deeper here in the PRP. The different protocol, what does it mean for us? The centrifugation variability will impact directly the platelet concentration. So we cannot compare 2 studies. They will be comparing apples and oranges because the concentration is different. And the concentration is different. We don't have standardized platelet yield definition. How much platelet should we have in the PRP injection to say that it is enough? Because this platelet yield will reflect on the growth factor quantification. So we cannot know how much growth factors are there in our injection. So there is no universal protocol. And unfortunately, the regulatory bodies didn't ban its use or didn't restrict its use or its protocol. So we have uncontrolled clinical application, and the manufacturers bypass the standardized requirements and go for extensive marketing of this medication. But again, here, all international guidelines agree that it's still not for clinical use, it's still observational, and it needs more studies. Coming here to the weakest link here, which is the stem cell therapy. The stem cell therapy, you will see, you will find less advertisement, but it's still there. Again, coming to the evidence, mainly from very few studies and predominantly small, uncontrolled. The number is very small sample size, the duration of follow-up duration less than a year. Blinding is very poor, and the outcome measures is heterogeneous, and the level of heterogeneity of the studies is very high. I found this systematic review, it's not a meta-analysis, and it's not of RCTs, because there is only one RCT found on stem cell therapy, and it is single-blinded even. It's not double-blinded. But you'll find out of the 13 studies, most of them are either a pilot study or phase 1 or phase 2, single-armed, as I said, or the only one double-armed is single-blinded. Coming to the patient population, it's heterogeneous. Diabetic patients, heterogeneous patients, post-prostatectomy, so we cannot compare studies together. The study size, as we said, and then the most important part, the stem cell therapy, the source of the stem cell. When we say stem cell therapy for erectile dysfunction, we're not talking about one medication or one modality. We're talking about different modalities, because stem cells are coming now from adipose tissue stem cell, bone marrow stem cell, umbilical stem cells, or placental stem cells. So the mechanism, the source is very different. The mechanism of separation is very different. And we are getting a group of heterogeneous information or data with us here. So they said, although there is improvement, it shows promise as an innovative and safe treatment for organic erectile dysfunction. However, lack of standardized techniques and controlled groups in many studies hampers the ability to evaluate and compare its trials. And this is the meta-analysis that Dr. Manaf has shown us, the one from our group's friends from Turkey with Dr. Atish Kadoglu. They concluded that it is safe and may increase the score of questionnaires evaluated compared at 6 months compared to baseline. So 6 months is the maximum efficacy here that they found. However, comparative trial with longer follow-up periods are needed to draw more definitive conclusions and reveal long-term effects. What Dr. Manaf didn't comment on here is the safety profile for stem cells. Stem cells, we are talking about genetic material. So we have potential very serious adverse effect, carcinogenesis, immune reactions, off-target differentiation. We can grow cartilage or bone inside the penis. So instead of treating the patient, we are creating a monster or a mutant. Then the inadequate long-term monitoring for them to see the safety and the efficacy. When we come to the protocols, as I said, the cell source is very variable. The processing methodology is very variable, and the characterization itself for the stem cells is very variable. So there is no uniformity in this medication. Established therapeutic effect compared to the gold standard, I didn't find any meaningful study showing this increased superior risk benefit for stem cell over the regular therapies. Again, all international guidelines say that it's not for clinical use and it's still investigational. Coming to the gene therapy, here they identified some genes that are maybe target for gene therapy, like MAXK, the VEGF, and the endothelial nitric oxide synthase. These are responsible to regulate smooth muscle relaxation, angiogenesis, endothelial nitric oxide production that are important for erection. They can be delivered through viral vectors, naked DNA, or live infection approaches. These are different types of introduction or delivery of the gene therapy into the penis. And when they are injected into the cavernous tissue, concentrated into the cavernous tissue, theoretically, they will regenerate the penis and improve its action. However, this study is still not there due to, when we find the evidence for them, there is no actual clinical study showing its efficacy. They are either preclinical phase 1-2 studies, and there is no regulatory review for it up till now. But as I said, the regulatory and safety barriers to gene therapy to be used like the other sorts of regenerative therapy is much, because the preclinical testing needs comprehensive off-target gene effects to be evaluated. Because when I do a gene therapy, I may change it to a monster, and this should be very rigorous studies to study this. The manufacturing itself should be standardized with quality control procedures. The long-term safety profiles of gene therapy is mutagenicity, carcinogenicity, and mandates extended evaluation. And thankfully, the regulatory approval here is very strict. It needs highly restrictive agency approval processes and complex approval frameworks for its use. This is what makes it up till now not commercially and technically feasible as a treatment for erectile function. Coming to our fourth body of evidence, when you compare regenerative therapy to the established PDE5. Dr. Manaf said very well, the PDE5 is just a temporary treatment, but it is a treatment. Is regenerative therapy really a therapy here? Does it really regenerate? Does it really have the good evidence to be offered as a replacement treatment? Let us see. This is a very nice compacted table to see the difference between them. The biological basis, very well defined in PDE5, but theoretical and heterogeneous for regenerative therapy. Although the theory is there, but it's still a theory. The clinical trials, more than 100, very few. Number of subjects, more than 10,000, even more than 100,000 if you consider all the studies, but here less than 100 per study. The design, double-blind, placebo-controlled, usually unblind or very weak sham. The efficacy, up to 60 to 80% increase of the set, variable and inconsistent. The placebo-controlled, strict, strong separation from effective placebo to the effective medication, but here it is, they usually overlap. The safety, it's been there for a long time, so we know the safety for it, but here long-time data is missing. Protocol standardization is clear, but here heterogeneous. Follow-up period long, short, adverse effect well-characterized, poor. The cost, here it is $5 to $15 per dose. Here it may reach up to $1,000 for some of the medications. And for the guidelines, first-line therapy, but here investigation or conditional use. So I don't believe that it will replace the actual therapy now. The regenerative therapy will not replace the PDE5 as established option because of all what we said. And there is one important part that when we use it now, we may delay the effective treatment with PDE5 for these patients. Delaying the treatment will elongate the area, the period of erectile dysfunction, which may psychologically affect the patient and lead to exacerbation of his erectile dysfunction. Coming to the GAF evidence, Dr. Manaf have said our study, the survey study was coupled with expert opinion and compared to the international guidelines, and there were different statements regarding regenerative therapy. They say that it appears more effective in patients with vasculogenic ED, mild to moderate ED, young and middle-aged males, can be used solo or in combination. Low intensity shockwave therapy have more evidence to support them. This is very good and in favor of regenerative therapy, but should not be considered the standard of care for treating ED and should be offered to patients with informed consent according to its current limitations. Limited proportion of patients with regenerative therapy for ED report satisfaction with treatment. The current evidence is unclear on the duration and the safety, although the short-term safety is good, the long-term safety is not yet identified. So coming to my closing argument here. Coming to the study design for all regenerative therapy, it's usually uncontrolled, mainly uncontrolled, inadequate blinding and controls, insufficient sample size, heterogeneous measures, inadequate follow-up duration. This will get us publication bias and very poor quality, selective reporting of the benefits and hiding the side effects or the decreased efficacy, the outcome bias because these are not really controlled, randomized controlled trials. Most of them are not registered. The trial registry is inconsistent, so it is not mostly unaudited. And there is a lot of gray literature that may affect the data present in the meta-analysis. And as I said, the meta-analysis, we take the data that's present and we try to pull it together. So if it is inconsistent, if it is biased, we'll get a pooled bias on the other side. So while the patient may ask for it, while the patient may need to be treated and not given a temporary treatment, but we have to say that the biological promise is not a clinical reality. The good biology doesn't automatically equate to proven clinical treatment. The good theory and the good targets for regenerative therapy and the good preclinical data or the early evidence that is there is not a guideline level treatment. So success in the lab doesn't justify the widespread unmonitored human application and unmonitored advertisement for this treatment. So from all this, I can really say that regenerative therapy for erectile dysfunction is a bane. I'm not against research, but I'm against marketing low evidence medication as an effective first line or effective treatment for erectile dysfunction. And with this, I rest my case. Thank you very much.
Since we got these clearly positions, either from Professor Manaf or the structured, really well done work, elaborated work by Professor Mohamed Arafa. So I would say maybe we should start immediately with the Professor Marcone, ask him immediately right now, because I think the first question would be a target for him.
Yeah, absolutely. Please go ahead.
PRP, you have done a lot of work. You have done a meta-analysis, and you can see that is surely not fitting with auto meta-analysis. How do you would convince the audience that we should do PRP? Please go ahead. 2 minutes.
Well, actually, it's difficult to say. I definitely agree with Mohamed that to date it's become difficult to sustain the use of PRP in our clinical practice. We must be honest, we are scientists behind all, and we must consider that the treatment for our patients should be the best and not marketing related. So if we see the evidence, we just published a few months ago our meta-analysis on the PRP outcomes overall. And even if results seems to be promising, I mean, the number of RCT, it's really limited. And there is a big heterogeneity, as Mohamed has showed us, among the kit preparation, the number of vials that are administered, the intervals, the follow-up. We lack actually of clear evidence to and outcomes that are perfectly selected to clearly compare the studies. So it's really difficult to give a clear recommendation nowadays for PRP. And you know that I'm part of the member of the EAU guidelines. So as a panel, we decided to support in few cases, in selected cases, the shock waves. That's something that other guidelines have not actually done over worldwide. But for PRP, to date, according to the investigation that we have, we must stick to the clinical trial setting.
So, Bob, I think that was a clear comment, particularly because we all know that you have done your own meta-analysis, including some numbers which showed, at least according to your data, some efficacy. Scoring for was modest, 3, but it was at least there. Now, I would invite Professor Vidi Admoko from Indonesia. So we heard right now from both of the debaters the benefits and the potential benefits for the shockwave therapy. Indeed, if you listen exactly to the talk, the RAL structures talk by Mohamed, he clarified a clear difference between each modality, and each one was a different weakness on level of evidence, and he underscored it exactly. So now we are going to the shockwave therapy. Vidi, what do you would say here for our audience? Shockwave therapy, is that good?
Yeah, so thank you, Professor Germar, and also thank you, both Dr. Manaf and also Dr. Arafa for the great learning opportunity. So, in my experience during my clinical trial, so I'm personally in favor of the regenerative therapy. So, when performed according to the available protocols, so like the shockwave and also the PRP can be effective. So, although only in selected patient populations, but however, as presented by Dr. Germar, the recommendations for these therapies are very low to very low because high quality studies are limited, I think. And with the addition of the new therapies like Botox, Exosome, and also the other injectables, I believe the most important step toward is to conduct the high quality studies. And I will share my perspective on how we should this. So, based on our GAF recommendations, we can see some gaps that still exist. So I think some issues that need particular attention. So the first is the need for the studies for the long-term follow-up. So this is particularly concerning as some studies have clearly shown that the efficacy of the like the ESWT may not be permanent and also deteriorate over the time. So it may be reflect that during the treatment process, it can boost the psychological process of the erections, but the true regeneration but maybe not occur. And secondly, I think the study should pay a closer attention to the patient selections. So as some studies do not clearly specify which ED populations are included. So I think therefore moving forward, studies should clearly report the exclusion of the patients with the severe ED, the older age, and also maybe the long-standing diabetes or the ED following the prostatectomy. And also the third issue is about the clear variability of the available of the protocols. So like this presented by the Professor Germar, Professor Manaf, and also Professor Arafa, the placebo effect may be a crucial confounder. So I think like the for shockwave therapy, while the evidence is stronger, we still do not know the energy of the density, the frequency of the treatment, and also which type of shockwave is the best. And lastly, maybe once the best protocols are established, maybe we should focus on the determining with also the combinations of the regenerative therapies that are most effective, whether the PDFF inhibitors or in combination with another regenerative approach. So I think once these issues are addressed, the newer approach, but maybe like home-based shockwave therapy, we can be explored to improve the confidence and also to help address the limited time frame of the effects. So I think that's my opinion for this. Thank you.
Thank you very much, Professor Vidi. That was great because I see that you are still open-minded to combine different approaches, but still you're limiting that sometimes or until now we have some academic limitations in the study quality. Indeed, maybe I will come back here. Was one question in the audience. Someone is asking you, is there any difference in the results by the shockwave therapy in the flaccid penis versus induced erection? But I think basically, do you agree that normally the shockwave therapy will be done not in the erect state, or is someone doing that? Manaf, are you doing that in erect state?
No, actually, definitely no.
Okay. The same for Vidi? We are switching from East to Indonesia.
Yeah, I usually do some ESWT, but not in the erection state.
Okay, great. So I think then we have completed here this answer, this question by the audience. And therefore we were moving and including the question even from the audience, the most difficult issue, critical, if you're following the talk by Mohamed, is definitely the therapy, the genetic therapy, stem cells therapy or exosomes therapy. So I think there have been some concern, really deep concern raised up and well formulated. But I know that someone in Turkey is doing that, that has some preference and some experience, which we don't have it. So therefore, I'm delighted that we can ask right now the experience by Professor Tuncay Toprak from Turkey, because I know he explained to me that he is doing that. Maybe please comment only on this exosomes therapy and not the combination therapy, because that's then coming up to confuse too much. Would you say, what do you believe now? Who is the blame, Manaf or Mohamed?
Okay, thank you, Dr. Germar, very much. And I'd like to congratulate Dr. Mohamed and Dr. Manaf for their excellent presentation. In fact, I believe that both of them have valid points on this controversial topic. As someone, as you said, who frequently applies regenerative therapies, I'd like to share my own clinical experience in this topic. First of all, shockwave therapy should be considered separately from other treatments. This is because the level of evidence supporting shockwave therapy is significantly stronger compared to other modalities, and it has already been included in clinical guidelines also. Regarding stem cell therapy, as you ask, I'd like to highlight an important issue. In clinical practice, many treatments presented as stem cell therapy are actually stromal vascular fraction therapy, which contains a relatively low proportion of true stem cell. Stromal vascular fraction contains at most around 10% stem cells and therefore cannot be considered a pure stem cell therapy application. Secondly, the differentiation capacity of mesenchymal stem cells is limited. Therefore, the expected potential of differentiating into other cells types in practice quite restricted because mesenchymal cells doesn't have much more differentiation capacity. On the other hand, the use of embryonic stem cells raises ethical concerns, which has limited research in this area. When it comes to the exosomes, there are also many different sources available on the market, like plant-derived autologs or heterologs exosomes, which makes it difficult to assess their true clinical bioavailability and effectiveness.
Ada di tengah, ada di tengah. Ada di tengah. Papa takut jatuh.
Can you turn on, sir?
Similar challenge
note it.
also can be applied to PRP therapy also. Botox, in contrast, is not a regenerative therapy, and we can exclude it in this discussion. Finally, I believe, in my experience, I believe that treatments involving growth factors such as stem cell therapy, PRP, or exosomes may be more effective when applied after a therapy like shockwave therapy because these treatments tend to show better engraftment and enhance effects in tissues where a certain degree of inflammation has been induced. If we make an inflammation via shockwave therapy and then if we apply exosomes or stem cell therapy or PRP after shockwave therapy, it may be more effective. In conclusion, although all these therapies are promising, they don't create a miracle, at least for now, and there is a clear need for well-designed clinical studies. Thank you so much.
Thank you very much. You expanded more than expected from your experience because I know you're doing that a lot. So I think from my side, I have to congratulate and my warmest helpful thanks for these high-valued presentations. I think Professor Rupin is here on board and delighted to hear you, to see you in India, maybe late in the evening. Hi, Professor Rupin.
Hi.
You are going, you're so kind right now to make a summary from these different positions. I think there are some questionable positions, and because something is the feeling, something is the science, something is the correctness, something is the wish to do it, and some is the personal experience what you have to do it. So may you can summarize for us again, so that at the end, all the audience which are here know exactly when they're filling out the QCR code, what is the real procedure, blame or not? So that is the question which will be a question at the end of the day, and I will share the after the QCR code. Thank you.
Thank you very much, Germar, and I must congratulate everyone for excellent presentations, starting with the introduction by our moderator, who laid out the fundamentals of regenerative therapies, very good review of literature by Dr. Manaf, and then a very critical review of how the evidence should be reviewed by Professor Arafa, so that the end point was a very thought-provoking discussion whose conclusion is actually fairly straightforward, that there is evidence of physiological effect on the penile erectile mechanism of these, what we term as regenerative therapies. The best evidence is that for low-intensity shockwave therapy, and there is some provisional evidence for PRP and other modalities. The problem, as I see it, goes beyond the evidence that it could help. I think too often uroandrologists are becoming lazy. When the PD5 does not work, the next step is, okay, let's take the patient for a shockwave or a PRP based on whatever equipment we have. And the general implied approach is that these are standardized, recognized paths of therapy. And that is where we err. We need to recognize, and when I was looking at the questions in the chat box, a lot of people asking, what should be the standard protocol for LISWP? How do we prepare the best PRP? Again, implicit in each question was the belief that these are standard therapies. And that is where we need to step back and recognize that these are not yet standardized. The correct protocol can be understood if we distinguish between penile rehabilitation versus sexual rehabilitation. Sexual rehabilitation is making a man capable of intercourse by giving him a good erection, and that sexual rehabilitation comes from standardized therapies, which are the PD5 inhibitors, the intrapenile injections, or the penile implant. Penile rehabilitation is a bypass, where in some cases we feel that this penis is functionally deficient, not very severely so, and perhaps through a course of treatments, we might be able to rehabilitate it and restore erections in the long term. And therefore, they're parallel pathways. We need to treat patients and restore erections using standard therapies, and in well-defined experimental clinical groups, we may take up some patients and see whether regenerative therapies can work for that group. If we, and a lot of us are doing that, take patients for shockwave or PRP, in every case that fails or refuses a PD5, we are being lazy, we are not being fair, and I suspect a lot of the men who respond to regenerative therapies were actually men where psychogenic ED was predominant, and they just responded to the therapy. Friend of mine who was running a trial in the US, when I asked him, how are your patients doing? He said, Rupin, I have to confess that the ones who are doing the best are the ones who I think may have psychogenic ED. So the bottom line take-home message here is that just because you've invested in a machine does not mean that every patient you see is a candidate for shockwave therapy. At the current level of knowledge, with the current guidelines, with the current conclusions of most systematic reviews, ideally, as of today, regenerative therapy should still be part of well-defined, well-controlled clinical studies. And in future, we will know where this pathway of therapy fits into the standardized treatment. So this was, of course, my perspective, super added upon the excellent arguments that have been provided by all the speakers. And thank you very much for attending and for inviting me to sum up this meeting.
Thank you very much, Rupin. I ask Dr. Germar to provide the slide for the QR code.
Thank you very much again, Professor Rupin. You're summarizing it, and Professor Ashok Agarwal, because I think it's thanks to you that we have here so many people around the world which are following our discussion with high interest. And maybe it's the key point right now to understand that maybe topics which today hadn't been addressed in detail will be in the future again the next issue what we have to present. So I'm thinking about Botox, which is obviously not the classical, as mentioned, not the classical regenerative therapy one. So I'm sharing it right now. My last slide. I hope I'm done right correctly. Can you see it? I'm not sure. So again, from this side now, I wanted to thank you for all you have been joining us until the end of this long afternoon. So from the name of the GAF management and all the organizers, Dr. Hiva in the background, who is doing a lot of work for us in the technical issues and all the teams in particular. So we hope definitely that this series has been a valuable resource for your daily practice, and you're delighted that we have done it in this way. Obviously, for the outstanding presentations, and showing us how we can elevate the standard of care, how we have to be academically correct. We have to make a special thanks either for Dr. Al-Hashimi, who is presented how he is dealing that with the situation. Apparently, he has more experience, more requests in his region. And the other side, for again this excellent talk by Mohamed Arafa, who is really academically correct in differentiating what is the actual stand and what should we know or not we know. So with your dedication, I think you have done a great value, and it will helpful for all of us definitely when we have to think about how to treat our patients. So we extend our heartfelt gratitude for all the faculty's members who helped us in this series. Each presenters both unique clinical insights. Each commentator have been amazingly great, and they bring together all their experience. So it was highly international and highly impactful series. And if I'm looking where the faculty number is coming, you see that was again a GAF series of online meeting free of charge. And again, you see the unique of the experts. That's the reason why I'm calling that really a global GAF, global community, which is good friends we are sharing exactly. So at the end, I'm showing here now one slide, which I am going to request that you take a picture about this QCR code. This is helpful because you will earn right now your credits in terms of certification, which will send you automatically by email hereafter. Please scan this survey with your smartphone. If there are any issues, then we can try to resend it again to you by request, but basically scan it right now, then you have the open link, it's working. And if you have done that, you have done a good job, even less for us, because we are learning how we can improve. Our aim is always not to stop, to increase continuously. to make better, make science better, and make, in these terms, even less, the educational aims from the GAF better. Therefore, thank you from my side. I would say until the next time, trust me, the next invitation will come. Stay curious, stay compassionate with us, and keep healing. And please do not forget to start with this one. Thank you very much.
Thank you very much, Dr. Germar. The meeting has ended now, and we will encourage everyone to complete the survey through the QR code shared by Dr. Pinggera. That will entitle you to receive a customized certificate with your name delivered directly to your email as a PDF file. So it is very attractive. It is customized, and it will carry your name, which you can display, you can share with your department, your administration. It is part of the continuous medical education as a proof of your attending this academic program.